You
Yes.
can. Now we are on live. Sharp 7 will start, sir.
Sure.
Hi, good evening, everyone.
Hi, ma'am. Good evening, ma'am.
Hello, good evening, ma'am.
Hey, good evening.
Good evening.
Hi, good evening, everyone, for joining this meeting webinar. This scientific event is organized in collaboration with Molecular Pathology Association of India. So I would like to welcome Dr. Vivek, who is the EC member and from Molecular Pathology Association of India, to set the context and take the event forward. Over to you, Dr. Vivek, sir.
Thank you, Mr. Shrikant. Let me start it. On behalf of Molecular Pathology Association of India, I welcome all the esteemed members and delegates for attending this event virtually. And let me take this moment to proudly state that Molecular Pathology Association of India has organized 3 hands-on training workshops to the pathologists on HER2 low, ultra low scoring and interpretation. And we have also conducted a series of webinars on different topics. This is the 7th webinar of 2025. So today's webinar on ESR1 testing is the fact that detection of mutation is at the forefront of molecular biomarker testing. And it is very important to know the ESR mutation, because it allows the clinicians to personalize the therapeutic strategies, refine the NGS endocrine agents, and combination of treatment can be also followed after the investigation of this ESR1 mutation. So the integration is of sensitive diagnostic methods such as liquid biopsies, further enables the real-time monitoring of resistance and guide the optimal therapy selection. Advancement in targeting ESR1 mutation represents a significant step, which is through the precision medicine, and it improves the patient outcome with metastatic breast cancers. So NGS are preferred for broad genomic profiling and simultaneously testing of ESR1, PIK3, and other actionable mutations. So with this webinar, we will try to understand more about the ESR1 and PIK3CA molecular profiling, and what are the recent advances in hormone receptor positive and HER2 negative metastatic breast cancer. So to invite to our meeting or this educational event, I will invite Dr. Amit Ratan to take this session on redefining treatment paradigm for hormone receptor positive and HER2 negative metastatic breast cancer. Can we have a slide? Yeah, it's already there. Over to you, Dr. Amit.
Thank you, Dr. Vivek. Good evening, everyone. I thank the organizers for this opportunity. So let me start sharing my slides. Yes. Yeah. Are the slides visible?
Yes, sir.
Great. Okay. So what we'll do quickly is talk about the treatment paradigm for HER2, hormone receptor positive, HER2 negative metastatic breast cancer, and how the paradigm has changed and is continuing to evolve so rapidly in our present day era. We started off a long time ago with tamoxifen. We got the AIs. We got fulvestrant, and then we moved forward. And it's been a decade since we started with the CDK4/6 inhibitors. And then now we are moving very rapidly to different combination therapies. And the type of combinations are changing, and there are multiple types of drugs. And all of us have to kind of understand, where are we going to put these drugs? Which patients are we going to use these? And how are we going to use this in our practice? So this is one change which happened after CDK4/6 got introduced. This is when you get a hormone receptor positive patients, metastatic in the first line, clearly using a CDK4/6 in combination with hormonal therapy, that is the best treatment. There's really no doubt about it. We have three drugs: palbociclib, ribociclib, abemaciclib. Whichever we use, when we combine with hormonal therapy, we are doubling our progression-free survival. We talked of progression-free survivals of 12 to 14 months, going to 24 to 28 months by using this in the first line setting. And this is established standard of care. These days, we really don't debate too much. We directly start a CDK4/6 and a AI drug as a first line therapy for all our hormone receptor positive patients. Now, most patients will do well, as I said, in about 2 years, and then a group of patients will start resisting treatment, and then there will be progression. And that's the whole situation, that hormone resistance always develops with time. And if you look at it, in the first line setting, your hormone receptor resistance is actually only about 10% of patients. But as you move from first line to second line and second line to third line, what you see, more than 80% of patients become resistant to endocrine therapy. And that is what the whole understanding is. Now, what we are understanding, how does endocrine resistance develop in patients? Now, when we treat them with first line endocrine therapy in combination with CDK4/6 inhibitors, and when they progress, we say the resistance is developing in two different ways. One, it could be a estrogen receptor dependent resistance, where there is no bypass resistant mechanism which has taken place. And these are most commonly due to the estrogen receptor 1 mutation, or the ESR1 mutations, what we say. And with the ESR1 mutation, the patients can become resistant to the endocrine therapy. The other way by which they can become resistant is an estrogen receptor independent resistant mechanism, where they can develop a bypass pathway resistance. And the most common one we have seen is the PIK3 pathway. Earlier we used to say only PIK3 mutations, but now we say it could be the PIK3, it could be AKT, it could be mTOR, it could be PTEN loss. So basically the whole PIK3 pathway can become mutated and the patients can develop resistance. CDK4/6 resistance, this is something very, very difficult to, it definitely develops, but we really don't know much about it in detail. There's been a lot of studies trying to say, yes, if you have a RB loss upfront, your CDK will be resistant upfront. But yes, otherwise, we really don't have mechanisms by which we can overcome CDK4/6 resistance as of today. So these are the two ways we talk. It could be endocrine receptor dependent, the ESR1 mutation, or it could be PIK3 mutation, or it could be both. There can always be both types of mutations developing, and that's why your patient is becoming resistant to first-line therapy. Now, our whole goal when we see patients of hormone receptor positive patients is we want to treat them with hormonal therapy through multiple lines of therapy. We want to go through first line hormonal, second line hormonal, third line hormonal, and only then we want to get to chemotherapy. We don't want to jump from immediately to chemotherapy for various reasons. Chemo brings quality of life down. Yes, it has its own chemo-induced toxicity, and no patient wants the chemo toxicity. So every patient would ask, can we delay chemotherapy as much as possible? And our whole aim is delay it as much as possible, maintain a good quality of life, keep the disease under control, and keep increasing survival. And how do we do it? We do it from moving from one hormonal to the second line to the third line, and then we start getting into the other lines of therapy, which could be ADCs in the present era, but and eventually we do get to chemotherapies. Now, the first line is very standard. It's the problem is what happens to patients when you're on second line. Now, second line, earlier we used to say fulvestrant was our drug of choice. That was many years ago. Then we said some patients you could do fulvestrant plus CDK4/6 inhibitors. We did say patients with, there was a small group of patients we used to treat with everolimus exemestane with the Bolero study. That was another group of ways by which you treated patients. But what we saw, if patients in the earlier era who got only hormonal therapy and progressed, they responded very well to fulvestrant. They were the ones who did well. But in the present era, when patients got CDK4/6 upfront, fulvestrant is giving us a very poor median PFS as a single agent. And that's where the whole thought is, we want to get better and we want to use combination therapy to improve the progression-free survival. Now let's talk a little bit about ESR1 mutation. ESR1 mutation, what it means, there is a mutation in the estrogen receptor. It's usually a mutation which occurs in the ligand binding domain of the receptor. And what happens is, in this situation, when the mutation is present, these patients, the estrogen pathway is constitutionally always active, irrespectively of the binding. Now, this is a very dynamic mutation. This mutation usually is present only in 2 to 5% of patients initially, but it evolves over time. It develops on the time when you treat patients with aromatase inhibitors, and then the percentage can go up to 20 to 30 to 40% of patients as they are treated more and more with aromatase inhibitors. So, a very dynamic mutation. What was seen with patients who have ESR1 mutation, they have a significantly shorter median overall survival. Now, also what we saw, there was a study called the SOPHIA study. What it did was it looked at in patients with progression, if you treated them with aromatase inhibitors or if you treated them with fulvestrant, did it matter if they had ESR1 mutation or not? And what we saw that if patients on aromatase inhibitors, when retreated, patients who had a ESR1 mutation, they did not respond to an aromatase inhibitor, but they did respond to fulvestrant. And if they didn't have an ESR1 mutation, it didn't really matter. Aromatase inhibitors and fulvestrant gave us the same result. So clearly telling us when you develop an ESR1 mutation, aromatase inhibitors are not a good drug to use. And then probably you should move to a drug like fulvestrant, which is a third group of drugs. Now, uh, we have drugs. When you have a ESR1 mutation, now we saw drugs which are oral SERDs called selective estrogen receptor degraders, and these are the ones which have shown better results than fulvestrant in the ESR1 population. And this was the Emerald study which looked at this patient group, and what we saw, we did improve the progression-free survival in patients when you with ESR1 in the whole population when you use elacestrant versus fulvestrant, but the major benefit came out from the ESR1 population and not from the rest of the patients. So that is why Emerald was the first study, and elacestrant was the first drug approved as an oral therapy for patients who have an ESR1 mutation. So instead of fulvestrant, one could go towards elacestrant-based treatment. Now, last year, San Antonio, we saw the results from another oral selective estrogen receptor degrader, and this one is called imlunestrant. Now, this is the EMBER-3 study. Again, looking at the same population, you have patients who have received aromatase inhibitors and have progressed. And there are also patients, a good number of patients received aromatase plus CDK4/6 inhibitors and have then progressed. And they were randomized to 3 arms. They either got imlunestrant, the new oral SERD, or they got fulvestrant, which could be the standard of care, or they got, later the trial was amended to include this arm, imlunestrant plus abemaciclib. So you're rechallenging the CDK4/6 inhibitor. And what we saw in this, clearly, when you compared imlunestrant single agent versus fulvestrant, you had a benefit in the ESR1 mutation patients. There was a clear progression-free survival benefit, 3.8 months going to about 5.5 months, hazards of 0.62. But what was very interesting was when you combine imlunestrant with abemaciclib, which is rechallenging your CDK4/6 in many patients, though some patients may not have received it, you got an improvement in comparison to even imlunestrant. 5.5 months with imlunestrant went up to 9.4 months of PFS. So clearly, in this study, we see a combination approach of using an oral SERD plus abemaciclib is clearly giving you benefit. And this benefit was seen in ESR1 mutation patients and also patients who did not have an ESR1 mutation. Now, what we need to understand about ESR1 mutation is it is a subclonal mutation. So it gets better picked up on a liquid biopsy than a tissue biopsy. And that's the reason why you say you can do a dynamic follow-up of blood NGS and pick up blood ctDNA and pick up the ESR1 mutation. And it has been seen in various studies that the blood liquid will pick it up much more than a tissue. And with that, comes to the studies using ESR1 mutation as a dynamic marker looking for molecular progression. Now, this is a new term. We've never used terms like, we use terms like progression in cancer and solid tumors, but this is the first time in solid tumors you're using a term called molecular progression. All of you remember CML, we used to use these terms, ALLs, we use these terms, but in solid tumors, we never use molecular progression. So this is a revolutionary concept, which is evolving so rapidly. Now, PADA-1 was the first study, a phase 2 study. We say this study was ahead of its time, which actually looked at same way of ESR1 mutation, but using fulvestrant at molecular progression. But recently, we have seen the SERENA-6 study, a very, very novel study. Now, what this study did was, it said that patients who received first-line CDK4/6 with aromatase inhibitors, you start them on that because that's your standard of care, and you keep watching them by doing a blood ctDNA every 2 to 3 months and see who develops an ESR1 mutation. And those patients who develop an ESR1 mutation, but no progression on the scan, so they have actually not progressed, you randomize them to two arms. Either you continue your same aromatase inhibitors with CDK4/6, or you stop the aromatase inhibitor and add the new oral SERD, which is camizestrant, and with the CDK4/6 and continue that treatment. And this trial was looking at the progression-free survival. Now, what they did see, they had screened 3,325 patients. When they looked at it and tested for ESR1 mutation, 548 had developed an ESR1 mutation. So that's about somewhere about 18% or so, and that's what happens, out of which 315 were randomized to the two arms. Now, 51% of patients actually had the ESR1 mutation detected in the first test, and 38% had in the subsequent 2 to 5 tests, and 11% developed much later. Their testing was using Guardant NGS, looking at the blood every 2 to 3 months. Now, this is the progression-free survival. This was the primary endpoint. And what we saw, if you continued your patients on your AI with CDK4/6, you got a PFS of 9 months. But if you changed it to camizestrant plus CDK4/6, you got a PFS of 16 months with a hazard of 0.44. Clearly, you're increasing the progression-free survival with a very significant hazard. And also, the trend for the PFS2 also looks better. Now, this creates a lot of controversy, and I'm sure this will be discussed in the panel about how this is what implication this has into clinical practice. It really is it ready for prime time use, or absolutely are you going to wait for overall survival? Do you really believe in this data? Do you think this can be used into clinical practice? And I'm sure Dr. Shona Nag will bring all these thoughts into the discussion. But we call this trial very revolutionary. This is the first time we are changing treatment at molecular progression and not at progression on a scan. And we're seeing a benefit in the progression-free survival. Right. So this was about ESR1 mutation. Let's quickly cover up the PIK3 mutation. The second way of developing resistance, that is the PIK3 pathway. We know 40% of patients can have a PIK3 mutation. Now, this is different. PIK3 mutation is a truncal mutation. It occurs at the primary time, and you really don't say that it evolves and it's a dynamic mutation. Most patients would have it in the primary site, would have it in the metastatic site also. 40% have a PIK3 mutation, 5% have AKT alterations, and we're seeing 5% patients having PTEN alterations also, and then we are looking for PTEN loss, and that means there are 50% of patients where the PIK3 pathway is mutated and altered. Now, we have data of how to block this, and we have looked at it from the time a long time ago when you had exemestane everolimus. That was the Bolero study, and that was using a combination of uh, blocking an mTOR. Yes, this is still relevant in practice, but it's become less and less used because it's a little non-specific, and that's the reason why the usage has become lesser and lesser. But if you have a PIK3 mutation, the drug of choice has become alpelisib fulvestrant. Alpelisib is a PIK3 alpha inhibitor, and combining with fulvestrant clearly showed us in the SOLAR trial a clear improvement in progression-free survival compared to fulvestrant. So our standard of care had become alpelisib fulvestrant if we got a PIK3 mutation. Now we have some new combinations. We have the new PIK3 inhibitor called inavolisib, which is being looked at first line as a triple drug combination, inavolisib palbofulvestrant. And we also have the new AKT inhibitor, the capivasertib, which is being used in combination with fulvestrant. Quickly, alpelisib clearly improved PFS. There was no improvement in the overall survival in the clinical trial, but there was a subgroup of visceral mets where patients did get an improvement in overall survival. But we are worried about alpelisib usage because of the hyperglycemia. That's a toxicity where we need to always worry about. In our 120, we just saw the data. Inavolisib plus palbofulvestrant versus palbofulvestrant in a very high-risk patients, first-line group. These are patients within 1 year of adjuvant endocrine who progress and have a PIK3 mutation. And you use first-line combination of triplet. But why it is significant? You got a PFS and you also got an overall survival hazards of 0.67 in OS. This is the first time in a clinical trial by blocking a PIK3 inhibitor, you have overall survival advantage. So clearly this is practice changing, but yes, this population will be very small of those patients who got hormonal and progressed within 1 year. They are the ones who are the primary resistant ones which you will put them on. The new drug, capivasertib, this is an AKT inhibitor, and capivasertib is blocking the AKT pathway. Now, this is different from the other drugs which we were talking about, which were PIK3 inhibitors. But by blocking the AKT, you're still blocking the same pathway. And this is the Capitolo 291 study, which actually looked at patients on first-line therapy who progressed on AIs or AIs plus CDK4/6, and they were randomized to capivasertib versus fulvestrant. And what you saw, there was a benefit in the overall population, but the clear benefit was in the PIK3 mutant population, so the PIK3 AKT altered pathway. You have 3.1 PFS going to 7.3 months with a hazard of 0.5, a clear benefit. And they looked at all three subgroups and saw the benefit is there for the PIK3 population, for the AKT, for the PTEN. And that's where this drug is being looked at for clinical usage at progression of first-line combinations. Now, very interestingly, very recently, if you've seen, there was a press release of a new drug, a very uh, kind of again making us think. We keep saying pathways are important. It's a new PIK3 inhibitor. It's called get autolysive, which showed in a study called Victoria 1 benefit even in patients without PIK3 mutation, which is so surprising to see. And that's why we keep saying, the science keeps evolving and our understanding comes from clinical trials. And as you analyze clinical trials more, we get a better understanding. But yes, we are changing the concept of how to treat hormone receptor positive patients. First line, we do give CDK4/6 with AIs or fulvestrant. But second line, most of our patients, we look for mutations. And if we find ESR1, then it could be one of the SERDs or a combination. If you find a PIK3, it could be a PIK3 inhibitor or a AKT inhibitor in combination with hormonal therapy. And when they progress, then you go into the next line of hormonal therapy. And then you come into the ADC place where if they are low, ultra low, or 2 plus 1 plus, or the ultra lows, you would give them TDXT, and only then you would go into the chemotherapy arms. Last slide, we need to test. We talk so much about all these algorithms, but if we don't find the mutation, then we don't have ways by which we can treat our patients. And that's why all the guidelines say we need to test. Either you look for it via PCR, but nowadays we do NGS testing to pick up all the mutations at one go. But if we find the mutation, this is the way we use it as a precision medicine to treat our patients. And this I will end. Thank you very much.
Thank you, Dr. Amit, for this wonderful talk and educating us about the recent treatment advances in the HR positive and HER2 negative metastatic breast cancer. This was very informative, and I hope the audience have got wise on this topic. Now we move on to the next part of our agenda, and I'd like to invite the next speaker, Dr. Sushant Vinarkar, to take us through the details about the ESR monitoring in hormone receptor positive and HER2 negative metastatic breast cancer. Over to you, Dr. Sushant.
Thank you, Dr. Vivek, for the kind introduction. I am sharing my screen. Is my screen visible?
Yes, sir.
Yeah, it's visible.
Yes.
Thank you. So, ESR1 mutation, Dr. Amit Rotten has already introduced us to the clinical aspects of ESR1 mutation. And I being a pathologist, I would be introducing you towards the testing of ESR1 mutation. At the outset, I would like to let you know that I do not have a direct first-hand experience of ESR1 mutation testing in breast cancers. We at Tata Medical Center have started evaluating this, and there is a demand from our clinicians, and that is why we have started evaluating this. And since last 3 months, we are seeing how this can be incorporated into the clinical diagnostic service at Tata Medical Center. So whenever we start or we are into a phase of introducing a new test at Tata Medical Center, we look at different aspects before starting the tests. And I would take you through my presentations on this different aspect. So the first aspect that we look at, why to test the ESR1 mutation in breast cancer? What is the biology of disease? The genetic association with it? What are the recommendations? Is there any literature evidence available for this particular test? Second is which ESR1 variants are important in breast cancers. So it's a large gene, and which of this parts of this genes actually are important for the clinical aspects of the breast cancer treatment with the ESR1 variants. And third is how to test for the ESR1 variants. So once we are aware of the clinical relevance of the testing, now and the variants that are to be detected, we stress on the aspect how to test for the ESR1 variants. What is the techniques? What is the sample type? Are there any kits available already in market for testing? Because that makes life easier, so that we can apply the kits directly in the molecular lab. And lastly, when to test for ESR1 mutation in breast cancers. So why and when Dr. Amit has already covered very well. I would be focusing on which ESR1 variants are important and how to test. So, ESR1 mutation in breast cancer is an unmet need and what is call to action. So, this is what we are going to see through our presentation. So, the first question is why to test for ESR1 mutations? Is there any therapeutic, prognostic, diagnostic relevance for this particular gene mutation to be tested in breast cancer? Are there any recommendations? So, first thing we look at what are the recent recommendations or guidelines available. And the NCCN guideline clearly states that ESR1 mutation detection is necessary in advanced stage 4 diseases of the breast cancers, and they have given techniques, NGS or PCR based techniques. They have also mentioned that there are FDA approved agents if you detect this biomarker to be positive, and the agents are basically new generation oral SERDs that are there, that is selective estrogen receptor degraders, and these are elacestrant and camizestrant that are available in market. And the guidelines mentions to assess ESR1 mutation and progression following prior lines of endocrine therapy, ctDNA is preferred. ctDNA is circulating tumor DNA is preferred for testing of ESR1 mutations. So the guidelines mention that for therapy of advanced breast cancers, which are hormone receptor positive and HER2 negative, the preferred regimens are endocrine therapy, which is aromatase inhibitors, which are therapies like anastrozole or letrozole. And if the patients who are on this aromatase inhibitors progress, then the second line therapy or subsequent line of therapy with fulvestrant, which is basically a first generation SERD, is recommended. But it has been shown that the first line response is a key marker as the outcomes worsen in later lines. Here, it has been shown that more than 60% decline in median progression free survival is noted with second line treatment. And why is this so? Endocrine resistance plays an important role in the declining the efficacy of the second line and the subsequent regimens of therapy in advanced or metastatic breast cancers, which are hormone receptor positive and HER2 negative. So, what are the causes for this endocrine therapy resistance? There are de novo and acquired causes for the endocrine therapy resistance. Some of them are loss of the ER expression. So if the estrogen receptor is not present, the therapy of SERD or aromatase inhibitors will not act. Then there are crosstalks between the estrogen receptors with other growth factor receptors, subclonal genomic alterations of tumor suppressors or drivers. There could be other mechanisms or other genetic alterations which might lead to the resistance to endocrine therapies. And lastly, acquisition of ESR1 fusions or activating ESR1 missense mutations, which are the topic, the hot topic that is there at present, because there are therapies that are there, and a clear data is shown that this ESR1 fusions or activating ESR1 mutations actually lead to poorer outcomes with the subsequent line of therapies that are at present available. So, what is this ESR1 actually? So, ESR1 is a gene. It is located on chromosome 6, long arm of chromosome 6, 6q25.1, and it basically codes for a receptor, which is estrogen receptor alpha, which is predominantly detected in breast tissues. And this protein of estrogen receptor is a 595 amino acid protein. So, if the ESR1 is wild type, the estrogen receptors are not altered. And then there is a classical estrogen receptor signaling pathway, which is taking place in the breast tissues. Whereas when there is ESR1 mutation, that is the DNA level mutation is present, naturally the ESR1 mutations lead to altered estrogen receptors alpha, and this leads to altered estrogen receptor signaling pathway, which is basically independent of the estrogen. So, if ESR1 is wild type, the estrogen that is produced from androgens through the aromatase actually binds to the estrogen receptors, leads to receptor dimerization, and this receptor dimers actually act on the estrogen response element, leading to cell proliferation. And in this cases, the aromatase inhibitors are supposed to act. But whenever there is a mutation ESR1, the estrogen receptors are altered. And even if the aromatase inhibitors are given, this altered receptors lead to the estrogen response element activation, leading to cell proliferation. So, NGS-based deep sequencing has been attempted in breast cancers, and it has been shown that in prospectively sequenced advanced breast cancers, which are untreated, in hormone receptor positive and HER2 negative cases, the mutations which are more than 10% or which are recurrent or relevant are ESR1 and T53. There are other gametes of mutations which tail off. However, the most predominant ones are basically the ESR1 gene mutations and T53 gene mutations. The same has been documented in patients who have been treated. So, prospectively sequenced advanced breast cancers on treatment. Again, the ESR1 mutations are enriched, followed by MAP kinase pathway signaling gene mutations, and then transcriptional regulation gene mutations. These mutations are generally seen in post-hormonal therapies, as you can see in this black bar column that you are seeing. And it has also been documented that whenever this ESR1 mutation, MAP kinase signaling pathway gene mutations, or transcription regulation gene mutations are there, these patients with advanced metastatic breast cancer have a poor progression-free survival as compared to those who are wild type for these particular gene variants. Similarly, another study has shown that in newly diagnosed metastatic diseases of breast cancers of hormone receptor positive and HER2 negative, the ESR1 mutation frequency is quite lower. It is somewhere around 0 to 5%. But in advanced metastatic disease, that is the metastatic disease which has progressed further on treatment, the percentage of ESR1 mutations are higher. They can be up to 20%, especially who are treated with endocrine therapy. And a similar aspect has been seen with progression-free survival. ESR1 mutant patients have a poor progression-free survival as compared to those who do not have mutations. So, the ESR1 mutations are mostly seen up to 40% in patients who have received first-line therapy with endocrine therapy. And as the disease progresses, this ESR1 mutations get enriched, and the percentage of patients with ESR1 mutations are higher with second-line therapy and subsequent regimens. So, detecting ESR1 mutation before clinical progression addresses an unmet need. So, to detect the resistance to endocrine therapy, we require a biomarker, and ESR1 mutation is early predictor of acquired aromatase inhibitor resistance, that is endocrine therapy resistance. And what is call to action? So the pathologists are supposed to discuss ESR1 testing for identifying patients who can be informed well ahead for appropriate treatment management, or who can be put in clinical trials. So the unmet need is to detect ESR1 mutations before the clinical progression is there. So the second question is which ESR1 variants are important in breast cancers? So we know that ESR1 mutations have been documented on NGS-based studies. So which of these ESR1 mutations are important? So as previously mentioned, ESR1 gene actually codes for the androgen receptor alpha, which is mainly expressed in breast tissue. The most common ESR1 mutations that have been documented in multiple literature studies is Y537 amino acid mutations and D538 residue mutations. There are more than 51 amino acid positions that can be affected by ESR1 mutations, but most frequent ones are in the ligand binding domain. The ligand binding domain is the pocket where the actual estrogen ligand binds to the receptor, leading to the dimerization. Functionally, these variants are classified as hormone independent activating mutations, which are mainly Y537 and D538. Mutations which increase estrogen hypersensitivity, these are E380Q, K303R. And then there are some variants which are hormone dependent activating functions, which are basically S432L and V534E. So from this, we understand that ligand binding domain, the mutations which occur in the ligand binding domain of estrogen receptor, and the portion of ESR1 gene which codes for the ligand binding domain of the estrogen receptor alpha, the mutations in these regions are most important. So while most of the ESR mutations are located in hotspot region, there are certain mutations located in ligand binding domain which are more important as compared to the other hotspot mutation. And this Y536 to Y538 region is the most important to be targeted for the recurrent ESR1 mutations which are detected in the advanced metastatic breast cancers. So the third question is, now that we are aware what is the relevance of ESR1 gene mutation detection, which are the mutations to be targeted, we need to show how to test for the ESR1 mutation. So what are the samples, what are the techniques, and are there any relevant kits available in market for ESR1 mutations? So we know that the sample to be tested are basically patients who are progressing on endocrine therapy. As we can see here, as the patients progress, the percentage of ESR1 mutation increases from 5% to 33%. And further subsequent therapy, you can get patients up to 40% being positive for ESR1 mutation. So, testing ESR1 mutations at each progression during metastatic treatment course is important if they are not detected previously. So how are we supposed to test? We will have to do serial monitoring for ESR1 variants. Now, if we are supposed to do serial monitoring, we cannot be looking at tissue biopsies because every time you are supposed to get tissue biopsy, it's a painful procedure and it is not recommended. So then what is that we are supposed to do? So whenever at present in molecular diagnostics or in research, a serial monitoring is supposed to be taken up. Liquid biopsy is the answer. So, liquid biopsy ctDNA mediated serial ESR1 testing to detect acquired endocrine therapy resistance is coming up. And there is literature evidence that is available. So, real world data has demonstrated a head on comparison of tissue biopsy based ESR1 versus liquid biopsy, and they have shown that the liquid biopsy detection rate of ESR1 is higher as compared to the tissue biopsy. And the mutation detection rate increases with the subsequent line of second line and the subsequent regimen of the endocrine therapy for the metastatic breast cancers for hormone receptor patients. So Serena 6 trial, this was highlighted by Dr. Amit. They have used Garden 360, a companion diagnostic test every 2 to 3 months on patients who were on more than 6 months of endocrine therapy. And then they have documented almost 42% of these patients on subsequent therapy, on subsequent ESR1 liquid biopsy testing have shown ESR1 mutation. So ESR1 mutation is important in metastatic breast cancers with subsequent line of endocrine therapy. Liquid biopsy is the test to be taken into consideration. So the unmet need is ESR1 mutation is the early predictor for acquired endocrine resistance. ctDNA mediated serial ESR1 testing can identify patients who would be developing acquired resistance before clinical progression. So pathologists have to discuss ESR1 testing, and serial monitoring of ESR1 mutation is important. So what are the modalities that are available for ctDNA testing? So we are very aware that for ctDNA testing, we require the methods which are basically highly sensitive. So qPCR based testing, ddPCR based testing, and NGS based testings have been recommended. Each of these techniques have their own advantages and disadvantages. However, based on the literature that is available, ddPCR and NGS-based techniques for liquid biopsy detections are better as compared to qPCR-based techniques. These images over here are just representations of the techniques that are available. So we were evaluating qPCR-based assays, ddPCR-based assays. Next generation sequencing for liquid biopsy, we have not thought yet, or we have not taken up. But qPCR or ddPCR was in our mind. And then we went ahead to see which are the kits presently available. So we could get that ESR1 testing. There are numerous kits that are available, and we are at present looking at ddPCR based kits for ESR1 testing at our centers. You need to know that the ddPCR or qPCR based assays detect specific variants for which they are targeted, and they won't be able to detect all the available variants in the ESR1 mutations. So you need to use a kit which would be detecting more number of variants and which also has an higher sensitivity, because this is an liquid biopsy test wherein we are looking at ctDNA fragments within the cell-free DNA that we tested. For NGS-based testing, are there any kits available? There are numerous kits as well as companion diagnostic tests that are available for NGS-based testing. Many of them have a very good sensitivity of up to 0.1%. Many of them are research use only kits that are present. However, one advantage that NGS has, which we realized over ddPCR, is that it simultaneously allows us to detect other clinically relevant genes such as PIK3CA, BRCA1, BRCA2, AKT1, and ERB2 mutations within the cell-free DNA itself. So we do not require specific tissue for detection of this gene variants. So this is an advantage that NGS has over ddPCR. So whenever we are going to look for cell-free DNA based or ctDNA based mutation analysis or liquid biopsy to say, we are supposed to go through this paper, which is basically a recommendation by AMP and CAP. And this paper is very important because it highlights the irrelevant points that are required for ctDNA mediated testing. And I won't go into details of this, but the most important thing that this paper highlights is to describe the pre-analytical variables. So pre-analytical variables for cell-free DNA testing are very important. And the pre-analytical variable right from the collection tube to way the sample is collected, to way it is transported, the temperature, the time for transportation, the time when the plasma is separated, and basically the way it is tested. Each and every pre-analytical testing is very important. Recommendations have been given for cell-free DNA based testing, and it is important to follow this pre-analytical variables to be very specific that a proper cell-free DNA is extracted, or else we won't be getting the recommended amount of ctDNA for testing. So most important point is cell-free DNA based testing blood collection tubes, the Streck tube or Paxton tube, if the sample is supposed to be transported. You can use K3 EDTA based peripheral blood collection tubes also. However, then the tubes are not supposed to be shaken or rotated or inverted, and they are supposed to be transported directly, and the plasma has to be processed within 6 hours for cell-free DNA test. So the last question that we need to know is when to test for ESR1 mutation. I won't go into details. This has already been covered in last lecture, and with the previous background that I have given, serial monitoring in patients who are progressing on metastatic breast cancers needs to be done. And it has been shown that before 6 months and after 30 months, within 6 to 30 months, detection of variants is maximum. So after the endocrine therapy started, after 6 months of endocrine therapy, every 2 to 3 months, ESR1 mutation by liquid biopsy is supposed to be done till 30 months to maximize the probability of detecting the ESR1 mutation. So the key takeaways are ESR1 mutation detection is important to detect the clinical progressions from acquired resistance to acquired therapy. Once this is detected, ESR1 as a biomarker is detected, switch to a more better, newer generation sorts can be done. And the perfect test has to have a higher sensitivity so that cell-free DNA or circulating tumor DNA can be detected with ESR1 mutation. Liquid biopsy is the answer for detection of ESR1 mutation since serial monitoring has to be done. Liquid biopsy tests, which are highly sensitive and which cover the most hotspot, are the perfect tests. Costs, again, since we our patients are very sensitive with the cost, a low cost test is very important. And then, if the tests can detect additional genes, it can give an advantage over the other tests which can detect specifically the hotspot ESR1 mutations. So with this, I would stop and I would hand over back to Dr. Vivek for the panel discussion. Thank you very much.
Thank you, Dr. Sushant. It was very enlightening talk, and you have addressed the very key questions like whom to test, what to test, when to test, and how it's very important for everybody to know. Now, as we are running out of time, we move on to next last part of our meeting, which is panel discussion. I invite Dr. Shona Nag to moderate the panel discussion on ESR monitoring, addressing the correndum. The slide, can we have the slide for Dr. Shona? Yeah, and along with this, I also request to join Dr. Amit, Dr. Santosh, Dr. Mithua Ghosh, Dr. Vidya, Dr. Pooja to join as panelists and to take the discussion forward. Over to you, Dr. Shona.
Thank you for that. And I'm just trying to share my slides. Uh, Here we go. Okay. So is that okay? Can everybody see it?
Yes, we can see it.
Yes,
So, I'm really lucky to have two clinicians and three scientists, including pathologists, on the panel. And most of the stuff has just been covered so beautifully by Dr. Rotan and then our next speaker. So I'm not going to sit and repeat all this again. And we are very aware of primary and secondary resistance. But just to recapitulate, Dr. Rotan, in your practice, how do you define primary and secondary endocrine resistance in both adjuvant and advanced disease?
Yeah. Thank you, Dr. Shona. So we say patients in the advanced disease, those patients who have disease progression while on endocrine therapy, they are developing resistance to that, and
Resistance.
that is resistant therapy. Now, it's more trickier in the adjuvant setting where you have to look at the time period, whether the patients were on treatment for 2 years, and if they progressed within that, or whether they progressed after completion. And that always gets into a little tricky space for us, because it's something that I always have to just look it up and see. In the adjuvant setting, they finished 1 year, okay, they are primary resistant. Okay, they finished 2 years, they're primary resistant. So that's the way in the adjuvant setting. But in the
Absolutely. Yeah.
setting, it's very clear.
So I think that's perfect, and that's what we clinicians use. So we don't rely on molecular markers. We look at time since treatment, which gives us a pretty good idea of resistance in the clinic. All this data has been covered. ESR mutations also has been beautifully covered by Dr. Sushant. And we talked a little bit about the development of the SERDs, just to tell you that we've gotten better and better. And the development first was all based on the SERD activity, in the sense, no, 1 minute, I need to get beyond. Yeah, so when you look at the activity, you look at the degrading activity, and you also look at the antagonistic activities. So fulvestrant and the older drugs, elacestrant, were more degraders, whereas camizestrant, immunolestrant, these are more antagonists. And as the antagonism increases, the activity gets more and more potent. And these drugs are also a little different in that they have better and better CNS penetration. So I think these are a little differences to be pointed out in SERD development. And there is also a concept of functional allostery, which says that the conformation of the ER is always dependent on the structure of the ligand which binds it. And shape matters. And according to the ER ligand complex, there is different functional activity. So this is referred to as functional allostery. So let's go to our next clinician, Dr. Chelapura. Uh, what time in an MBC timeline do you check for three, and do you check for ESR? Do you check for one first and the other second? And a lot of us are limited by the availability of these newer drugs in our clinic. So we may not always be checking first line. So I'd like to get a sense from our clinicians. So, Dr. Santosh, when would you think it reasonable to check?
Thank you very much for the question, madam. So we see we are in a era where the things are very fast moving. So we did not have a lot of things 1 or 2 years before. Now a lot of things are moving. But in India, the availability is not yet available of these all drugs. So that changes my decision making of when to test.
Correct.
So what I
Correct.
do, what I want to do are two different things. What I do is I do not do any testing at baseline. So whenever they progress after first line, I check for both PIK3 and ESR1. This is what I do day in and day out on clinic. What I want to do is in first line, especially the highest risk of resistance, the included in the INNOVA trial, that is inavolisib, where I would want to do a testing for PIK3CA. If they are positive with the highest risk of recurrence, I want to give a triplet because it is the trial that showed overall survival benefit. So that is one. Upfront, yes, this one. And if they are negative for this one, after 6 months of start, as in the Serena strategy, you will start and doing it every 6 months. This is what I want to do. But as of now, I'm doing at first progression both PIK3C and ESR1.
Amit, do you agree, or do you have any different ideas? And how do you go about testing in your clinic?
So till some time back, all patients at progression after first line, we were doing ctDNA and testing for mutations. The recent times, we have moved it at diagnosis, also testing for ctDNA. But again, we know that the PIK3 mutation, even if you pick it up, we are not going to do anything about it because that segment is very narrow, the inavolisib segment, and it does not matter in the remaining patients. But we are still starting to do it upfront also. But that's about it.
I also think it prepares you prognostically to expect less from your CDK4/6 inhibitor, and to be, aware of the fact that you will at some point have to switch to either CAPI if it's available, or then deal with alpelisib. So just a clinical question, how happy are you with alpelisib? I'm quite miserable using the drug in the clinic. And I really struggle with sugars of 500 and 600, even in young patients, even in non-diabetics. They start losing weight there, they have rash, they can't eat. It's been very tough.
Absolutely, a very tough drug, no doubt about it. But the other side of it is we are still using it because we don't have any other option.
No, nothing. So I think we need to definitely have better options. And let's look at this treatment algorithm. This is precisely what we said. We've got a lot in the second line, but right now, genomic testing is recommended earlier and earlier, and it gives you a sense of the tumor and its biology so you can plan, and hopefully, more clinical trials will also be available. So, let's talk a little bit about ESR mutations. So let's come to our scientists because I think they deserve to have a word. So, Dr. Veldor, Dr. Vidya, is Dr. Vidya there?
Yes, ma'am. I'm here.
So Vidya, tell me, are you getting how many requisitions for ESR1 3 mutation testing are you getting? And are you getting liquid biopsies routinely asking for these tests?
We do get, madam, whenever there is a metastatic disease, after disease progression is when the clinician asks, is your panel already having an ESR1 or not? So that's the
Right.
question that comes. And in our experience in the lab, we have seen 40 patients with the ESR1 mutations. And
Wow.
all the 40 patients, it matches to the theory that is PIK3CA is co-mutated. Sometimes it is PTEN or AKT, but there are
Right.
three more lessons that I just want to share here,
Sure, sure.
which will become more monstrous down the line, maybe. That is FGFR1 and FGFR3 amplification as a co-mutation with ESR1. And another important aspect which probably could correlate to histology backwards is GATA3 loss. Out of
Yeah.
40 patients, there are 5 patients with GATA3 loss along with ESR1 co-mutation.
Okay.
Looks
And
like when... Yes, ma'am?
these mutations that you picked up, these 40 ASR1, were they matching in terms of incidence with the most common one that we're seeing?
Yes.
The
So,
Y537S
fine.
and the G538. So these were
Yes.
the common ones.
Yes.
Okay. So
There is one patient
Y537.
with 380.
Okay.
Yeah.
Because these Y537 are the most deadly ones. They have
Yeah.
a lot of antagonistic value, and that's the one that really drives the tumor. So, Dr. Mitwa, your experience with ESR1 testing, and how often are you seeing co-mutations between ESR1 and PIK3?
Yeah, so thank you, the organizers, for having me, and thank you, Dr. Shonanag, for this question. So basically, ESR was well known for a long time, but how we came to know that ESR1 mutation is prevalent is by doing comprehensive genomic profiling. The origin is from when we started doing comprehensive genomic profiling, we started seeing these ESR mutations a lot, either single mutation or co-mutated with PIK3, AKT, mTOR pathways, or other mutations like Dr. Vidya said, FGFR and FGFR2. So if I have to share my experience in last 1 year, I have done about 1,000 CGP in breast cancer,
Yes,
and there I have seen about
yes.
10 to 12 patients had ESR mutation. So it is almost 1 to
Okay,
2% maybe. And these are most common mutations, which we are the hotspots. And when I took the clinical data, because we have access to the clinical data, all these patients, except one, had a progressive disease, right? So now
okay. And
the way
was this a mix of early and metastatic breast? Or
These
was
are
it just
mainly
metastatic breast?
metastatic because, as you know, genetic
Right.
testing is recommended only
Yes.
when the first line and second line
Yes.
don't work, right?
Of course.
Fortunately or
Of course.
unfortunately. So this is what we found. And so that was a lesson for us because the clinical data was so bad, progressive disease, ESR, when we started giving a lot of importance on ESR. And this is before the era of elacestrant and other drugs, right? I mean, and then we started, the team started developing ESR by liquid biopsy, ESR by real-time PCR, because not all patients can afford to have NGS and a comprehensive NGS. And we
Of
started small
course.
panels with ESR, and that is how it is, progressing. But I still believe it should be a CGP or a mix of breast cancer panels where we have not only ESR, at least the PIK3, AKT, mTOR pathway, FGFRs, all those
So
can be.
you want to look at the comprehensive picture to get an idea of how
Yes,
all these mutations are affecting each other as well.
yes.
So my question to Dr. Pooja, is she there? Okay.
Yes, ma'am.
So
Yes, ma'am.
you're there. Pooja, what has been your experience with ESR1 mutations? Because would you rather suggest a liquid biopsy, or would you go for a CGP to look at the whole picture as mentioned by Dr. Mithua?
Yes, ma'am. So basically, I completely agree with Dr. Vidya and Dr. Mithwa. So we have also got many cases and one of the CGP. So I would like to add that we got ESSR1 CCDC170 fusion along with
Oh,
PIK3CA, yes, along with PIK3CA mutations and a gain in chromosome 11, which includes the CCND1, FGF19 and
right.
FGF3. So basically, yes, we are getting many other alterations along with, ESSR1, which gives us a complete picture to how to go ahead with the treatment. And even in the liquid biopsies, we got such cases where we got ESSR1 mutation along with PIK3CA or AKT1 mutations. So yes, when we go for NGS, we get the other information that will help the clinician to decide the treatment properly. So
When
I
you're
would also
doing a
suggest
liquid,
to go for
when
a
you're doing a
complementary.
liquid biopsy, excuse me,
Yes,
when
ma'am.
we're doing a liquid biopsy, do you
Yes,
just suggest hotspots? Because we did show that some mutations occur outside the hotspot domain,
yes,
and they
yes.
may have some sort of implication on treatment and
Mm-hmm.
resistance.
Correct, ma'am.
So, what
So,
is your
yes.
recommendation?
Yes, ma'am. So basically, whatever panels are available currently, they are mostly covering the hotspots
Right.
of ESSR1 gene along with other like PIK3C or whatever genes are available. They are shorter panels of 50, 60 genes. So basically, they also cover the hotspots. But nowadays, if you are moving ahead, we should also focus on the other parts of the genes which are other than hotspots that will, um, incorporate important markers which will improve the treatment later, but right now in the current scenarios people are doing only hotspot studies.
Okay. Thank you for that. Dr. Santosh, let's come to you. I'm feeling a little frustrated listening to all this because I think the testing has gone way ahead of the therapeutic options. And I know that we will be doing liquid biopsies. We will be picking up host of these mutations, including FGFR has been mentioned by all three. Where are the therapies for these patients? And we don't even have the newer pivasertib, inavolisib. We don't have any of these drugs, and let alone SERDs, we don't have pemetrexed to start with, which is really the basic search. How does all this testing make you feel?
One thing is, madam, having a drug somewhere in some part of the world, not having India, is a lot of frustration to us and extremely
Yes,
frustrating to the patient. So
yes.
sometimes what happens is, doing test tells us, yes, you have this option. We gave them an option of availability of the drug. Last 2 months back, I had a patient who had ESR1. They have resources in US. Their son and daughter stays.
Fabulous.
They
Okay,
went there and
okay.
started assistant. So basically, it's always very important to
How
provide.
is your patient doing on the drug?
2 months started doing fine, madam. LSS
Oh,
strength.
wow.
So
Okay. Amit, any experiences with these newer drugs? Because I'm sure some of your patients must have imported it. So
No, I
Capi,
have not.
Innova.
No, I have not used any of the SERDs yet, oral SERDs, none of them.
Oh, okay. Let's hope you get one soon. So I'll share my experience with Capi. So this lady came to me, ER positive, heavily pre-treated, given chemo after chemo after chemo, failed CDK4/6, and I think had received alpelisib for a month or something. No, she hadn't received any anti-PIK3, and it hadn't been tested either. So she comes to me, and we get a tumor testing done. In fact, a liquid biopsy, and we pick up a LKP mutation, and she had a fungating mass on her chest wall, and 2 years down, pretty miserable. I put her on capivasertib, I did like a 20% dose reduction. And apart from rash and pretty bad rash, she's doing beautifully well 4 months later. So, that's my single experience with these newer drugs. So I can't wait to get hold of some of them. Amit, did
Any
you had all
hyperglycemia?
these?
Hyperglycemia?
No, not yet. I'm
Good.
keeping my
That's
fingers
good.
crossed. But
That's
the
nice.
rash is pretty bad, warranted dermatologist intervention. But the fungation on the chest wall is gone. So she's happy, I'm happy, and we're waiting for the scans now. But tell me, if you had all this armamentarium and you did a mutation testing as per Serena recommendation, and you picked up a co-mutation of ESR1 and PIK3, what would be your go-to choice? Because there are no guidelines for these co-mutations.
First line therapy on without progression, then I think we're going to still wait for progression to happen.
No, I'm saying she's on CDK4/6 AI.
Okay.
And then you get excited. You have the availability of a reasonable liquid biopsy, and you start monitoring your patient because your patient wants to know what's happening 6 months out of CDK4/6, and she's clinically doing okay, and she has no progression on her latest scan, but we are beginning to see ESR1 come up. We're beginning to see a PIK3CA come up. What would you do in that situation?
I think these are situations where you'll start worrying, I'm sure, but I really don't know whether we are ready for prime time use of Serena.
Absolutely. I agree with you. I think the anxiety associated with this testing is going to be something we are all going to be handling in the clinic. As it is, they are nervous. When you get this blood test showing a mutation, and you have 75% of them had no radiological evidence of this. So it's going to be a tough call for clinicians. It's going to be very easy for the pathologists and molecular biologists, but it's going to be tough for us. So the bottom line is, now going on with the questions. You saw the testing positivity after single test, after 2 to 5, after 5 tests. So we can safely say from my panelists, and does Dr. Santosh agree, that we're not ready for prime time yet in the Indian scenario? Okay, all right. And do you anticipate any other challenges in ESR1 monitoring?
Madam,
I would like the pathologist to comment as well. Santosh, go ahead. You were saying something.
So the example of capivasertib is very, very useful, the way the drugs work. And I feel it's more refined version of alpelisib. So the toxicity has cut down. Possibly that is one reason, madam. The other thing that I want to tell is once we start these drugs on radiological progression or clinical progression, when we see the Kaplan-Meier graphs, at the 2 months, almost there is a steep fall of the Kaplan-Meier curves, after which they tend to separate. So that is after which the working of this drug happens. So what we feel that is, even with the most available SERT, there is some fraction of patients who progress. So
To
can
rapidly progress
we,
the first 2 months. Yes.
first month,
Hmm.
can we identify these particular patients prior, and these would be initiated on the molecular progression? That is where research should be focused on. That's what I feel. So that the rapid, those patients who progress rapidly, we can provide additional benefit. That is
I
my
think
point of view.
I absolutely get you. I think all us medical oncologists can have our eyes closed and draw that curve of CDK4/6, where you get this rapid decline in both groups in the first few months, indicating very, very bad disease. And Serena 6, if you look, actually didn't show that drop. So maybe doing something for a group of patients, not all, in the first 2 months is important. But I think the real challenge is going to be identifying which patients these are. I mean, we always get stuck with these biomarkers. We have a lot of mutations, but we don't have ones that will really, really, tell us who to treat and when to treat these patients. So I think that's a limitation in the clinic. Amit, this one is for you. So I'm not a lung cancer expert, but you do treat it. So we do see that if you do a liquid biopsy very, very soon after the treatment, you get a false negative result for actionable mutations. So do you think the same holds for ESR1? And we need to give a gap after therapy of a month or so before we use?
I don't think so, because these are patients who are on hormonal tablets, and
Correct.
really it should not matter. I think the technology is so good that you should be able to pick up the cell-free tumor DNA and do the test. I don't think it should matter in hormonal therapy at all.
Because it's not mutation directed therapy here. It's a very different ballgame, that you're dealing with. So, Santosh, do you agree that it
Madam,
doesn't matter when you test?
so possibly this concept was taken from the blood culture and antibiotics we give. Suppose we take a culture after antibiotics, this what like that. Possibly this applies to more potent chemotherapy or some types of molecule. I completely agreed with Amit sir that in a hormonal therapy setting, it should not matter whenever we take this thing.
Okay. Thanks for that. I will come to Dr. Vidya. Dr. Vidya, what is turnaround time for testing these mutations?
On NGS, it's about 15 days, ma'am.
Right.
Right now, we
Ah,
use hybrid capture and we don't
yes.
do only hotspots. We look at the
Okay.
complete ligand binding domain. We don't
Okay.
look at the rest of the gene because
Yeah.
evidence is there only for the ligand binding domain. So we look
Yes.
at all of them.
So
And
you're saying about 15 days is what you need.
yes, ma'am.
Oh. And we talked about co-occurrence of mutations. And so rather than hotspot and NGS would be the preferred platform where you would be able to pick up all these different mutations. And I think brings me to the end. So I'm going to ask my panelists for a message from each of them in about a few lines, just to what you think the future holds for breast cancer mutation testing and breast cancer care for patients with primary and secondary resistance. So, Santosh, let's start with you.
Yes. So one important thing is with availability of newer oral molecules, the patient quality of life with multiple successful oral therapy that gives very good quality of life, and these are potent molecules. So with available of multitude of options, we need to know what test to do, when to do, and we should inform our patients the right time point that we have to do. The timing of testing and this availability of more oral molecules, uh, availability of good oral molecules has a very good impression of on patient. Their quality of life is better, and the PFS and OFS is much longer, almost increasing to tune of more than 1 to 2 years currently, as we where we have to introduce
Absolutely.
ADC and all.
Absolutely.
Quality of life is most important thing. Yeah.
Amit, what about you?
Yeah, I agree. All of us should be learning how to test, what to test, when to test, as Dr. Santosh has said. I don't think we are there for molecular monitoring yet. That's the stage which we will probably follow the data, we will wait for survivals, But it is wonderful to see the
You
concept.
really think we'll get an OS benefit, Amit? With all these ADCs in the picture confusing everything, people are going to jump to ADCs in these resistant patients. And we are going to be wondering what the hell is going on. So
Absolutely.
I
I
don't
know.
think an OS is a bit ambitious. You know,
Correct.
I
Going to be a
mean,
little tricky. But why I am a little
so
surprised is,
let's wait and hope.
yeah, I was so surprised why Innova hit OS so fast. So that's why I keep
Yeah.
wondering maybe we will in some way or the other.
Yeah, but their selection, like you also brought out, no, was very, very particular. And these were the worst of the worst patients that you expected to do, really badly. But I think it's very intriguing. PIK3CA mutations, I would like to treat right from the outset with a triplet because all of us have experienced how badly they do in the clinic. So I mean, that's a very exciting drug for us. So, Dr. Vidya, any last comments? Don't say you want to test more and more things because we get into trouble.
No,
We don't
no,
have the
I
answers for the patients.
no, ma'am. Actually, at this point of time, since the drugs are not available, it is like paralyzing. I mean, you know that there is a problem
Absolutely.
and you are unable to act. It is really a
Yeah,
frustrating situation. So, I think it would be better when we have drugs in the market which are affordable, and then it will really be a fruitful experience for the patient. Most importantly, after
correct. And
spending so much money, what's the benefit they get to
yes,
hear, basically? Yeah.
true, true. Dr. Mithua, what about you?
Yeah, so ma'am, as a basic scientist, I will say a little different. What I feel is genetic testing is not only to understand what should be given, what should be treated, or what a patient should be treated with, it is to understand what should not be given. For me, that is more important. What should not be given, and it's better not to waste time and money giving those drugs which will not work for the patient. So for me, it's important to do genetic testing. Now I know the challenges of drug availability, cost, and all. And in an Indian setting, which I try to do is try to develop all kind of tests where patients can afford, whether it's a tissue specific test or a small panel or a CGP. Even if you talk about liquid biopsy, whether it is NGS liquid biopsy or ddPCR one gene testing. So I try to all
Yes.
kind of tests which will cater to all type of patients. But I confidently feel
I think you,
that testing is important.
I think you make a very fair point. Dr. Pooja, last words from you.
Yes, ma'am. So I completely agree with Dr. Mithwa that genetic testing should be there, that not only for the targeted treatment, but also for the to get the resistance information. So basically, but it should be done in view of patient care always. So when it is
Yes,
needed, that should be decided, and then the decision should be taken.
yes. Because, you guys do test, but we have to face the patient and then look at that list and say, I'm sorry, I found nothing much that
Yes,
I can offer you. So
very true.
it is a tough call for us. So I
Yes.
think with this we can end, and just I'd like to wish everybody a very, very happy Diwali and happy festive season, and all of you stay well.
Thank you
Same to
and
you,
happy
Thank you,
ma'am.
Diwali
Thank you,
to all
ma'am.
ma'am.
of
Same to
you.
Thank
you.
you, everyone.
Thank
Thank you,
you.
everyone.
Thank you so much.
Thank you, Dr. Shona, for moderating such a vibrant and a crisp discussion on the topic of ESR1 mutation. And now we are coming to the end of our session, and I'd like to invite Dr. Sushant to please propose a vote of thanks. And if there are any questions, please take them. Dr. Sushant, over to you.
Yeah, so I would first look at any open questions if they are there, but at present, I'm not seeing any questions
Okay.
from the participants. So I think I would go ahead. It was interesting to hear the panel discussion, actually. I mean, even for me, as I had said at the start of my presentation, ESR1 is not a very a prime time test that is happening at our institute also. Our institutes, the clinicians very recently have started asking for this, and that is where we started evaluating. And then we came to know that it is for a niche of patients who are they are thinking where therapy would be changed if this mutation comes. So, good to hear a discussion from clinicians pointing fingers at the laboratory, that the laboratory has gone ahead in testing, but the therapy is still not. I mean, it's available in some parts of the world, but it's still not yet come.
No, not
But
accessible to our people.
yes, but yeah, but somewhere the clinical trials are heading towards a therapy that would be possibly coming to India also, and I'm sure in future our medical oncologist would be relying on this test, taking it frequently once the therapies are available. So, to just summarize, the key takeaways would be ESR mutation is an important mechanism of resistance, acquired resistance to aromatase inhibitors. That is the first line endocrine therapies in hormone receptor positive HER2 negative metastatic breast cancer. One important takeaway is serial monitoring is required for ESR mutations, and the serial monitoring is possible through liquid biopsy. The platforms available for liquid biopsy would be DT-PCR or NGS, based on the cost implications that are there, based on the resources that are available for testing, and what we are looking forward from the tests. And towards the therapy side, already as per the clinical trial data, next generation oral SERDs are there. Probably what I could hear, they are not really available as of in India, but they are there. And once they are available in India, I think the testing of ESR1 mutation would pick up and would become an important biomarker in hormone receptor positive, HER2 negative metastatic breast cancer. The last point I always like to stress on is a multidisciplinary approach wherein clinicians, pathologists, molecular pathologists, and radiologists come together and then discuss out the cases and decide what testing is important, in which patient it is important, what would be the relevance, and what would be the outcome and how the outcome would be answered. So I think these are the key takeaways from today's webinar. So on behalf of MPAI and the organizing team, I extend my heartfelt gratitude to our speakers, Dr. Amit Ratan, our panelists, Dr. Mithwa Ghosh, Dr. Pooja Chaudhary, Dr. Santosh Chellapuram, Dr. Vidya Veldor, and again Dr. Amit Ratan, moderator Dr. Shonanak, for bringing out relevant points in discussion, both from the clinical side and the laboratory side. And to the participants and the attendees for joining us today in this webinar on ESR1 mutations, advancing precision therapy in metastatic breast cancer. A sincere thank you to Dr. Vivek for moderating the whole webinar, and the organizing team and the team and the technical support staff for making this webinar seamless and successful. So thank you once again, and I would look forward for participation in future academic sessions. So I would close the webinar and wish you all a very happy Diwali.
Sir, we have just one small announcement from Dr. Vivek about the upcoming webinars. Over to you, Dr. Vivek.
So as we are continuing with the series, we are having a 31st October another webinar, which is on lung cancer, and the topic will be emerging lung cancer biomarker, recent advances and diagnosis and therapy. So it's going to be very informative and very useful for the participants to enroll and stay tuned with us for the next for this upcoming webinar. post-Diwali upcoming webinar. Thank you.
Dr. Vivek.
Wish you a very happy Diwali and have a nice weekend. Thank you.
Thank you.
Thank you.
Bye, everyone. Bye, sir.
Bye everyone. Bye, sir. Bye,
Bye,
ma'am.
everyone. Bye. Thank
Bye,
you.
Happy
Dr.
Diwali.
Pooja. Bye.
Good
Bye.
evening.